Thank you so much, and welcome everybody to today's CAUTI Action Network webinar. I will be hosting along with my colleague Jennifer Palagi in Idaho, and we have 3 great hospital speakers to share implementation stories with you. As you may recall, I guess first I should do some housekeeping. We will be holding lines on hold until the end, so although we have 3 speakers, you can feel free to chat in questions or hold those questions to ask verbally, and we will address those at the end. If for some reason you need to put us on hold, don't do that, right? We want you to just be muted. So if you need to star 6, go ahead and make that option. I don't think that will be necessary since all lines are being put on hold by the operators, but avoid hold if that arises during the call. As just sense making, this is the 3rd in 4 prevention calls. We've been talking about 4 prevention pillars. The first call had to do with avoiding insertion. The second call had to do with inserting with confidence. And today's call is all about maintenance. Our agenda today, as always, mirrors what we've done in the past. We're going to kick it off with a patient story. We're going to do a very brief review of best practice. And then we're going to get straight into the hospital stories, implementation story. 2 from Idaho, 1 from Washington. We'll then have time for discussion and questions, and we'll highlight when the 4th and final webinar will be taking place. So with that, we will start with our patient story, and I'm going to have Mark from CAUTI Health take us down that path.
Okay, so this is Mark with CAUTI Health. Patient story, we had a 63-year-old male who was admitted in November. He was found down in his home with a core body temperature on arrival of 80 degrees Fahrenheit. Now, we've recently switched to a new technology. However, that technology is not available in a temperature-sensing Foley catheter. So a silver latex Foley catheter with a temperature-sensing probe was placed, as well as a rectal probe. On the 5th of November, he became symptomatic for catheter-associated UTI. The organism was susceptible to the new technology based on published in vitro data. So the question that I would pose would be, are the temperature-sensing Foley catheters necessary, in that sometimes they would lend to leaving the Foley catheter in for a longer period of time for convenience?
So we'll go ahead and advance the slide. And this is Jennifer Palagi with Qualis Health, and I am lucky enough to be sitting here with Mark Chavez at CAUTI Health in Coeur d'Alene, Idaho. And I was visiting his facility today, so we get to do this on site. But anyway, for this webinar today, we are focusing on maintenance. We like to, of course, look at our guiding principle, which is to make sure we're designing processes so that maintenance occurs reliably for every patient, every time, every shift, and every clinical caregiver. And that can be particularly difficult in the maintenance realm of catheter care. So we're looking at all of our resources that we have available to us and the best practices as they're laid out in some great resources. I turned mainly to the IHI improvement map. I thought they had a good set of 5 practices that should occur, and so the routine maintenance of do is highlighted in green. And these will be familiar to you because you guys work in this day in and day out. This is highlighting that we want to make sure that we maintain a sterile, continuously closed drainage system, that we keep the catheter properly secured to prevent urethral traction, to keep the collection bag below the level of the bladder at all times, but definitely not on the floor. We want to maintain unobstructed urine flow and to empty the collection bag regularly, but don't allow the draining spigot to touch the collecting container. So that's kind of the big 5 that drain out all the best practices. But what I also like is that there's practices that we need to make sure that we're not doing, and if we're seeing them, we need to intervene and make sure they don't become a common practice on the floors, such as irrigating catheters, except for in certain cases where it's needed. We do not want to disconnect the catheter from the drainage tubing. And we don't want to replace catheters routinely. And if you have to use aseptic technique. Also, we're going to talk about cleansing today and peri-care, but you do not want to clean the periurethral area with antiseptics while the catheter is in place. Can create an area ready for infection when that happens. And we don't want to break the junction between catheter and collection tubing when collecting for urine samples. So there's your green light and your red light. And moving on to the next slide, this is just an example of how you can take a common set of practices like that of doing things of the green light and turn them into a bundle, such as a CAUTI maintenance bundle. And so you have that in your slide deck and a reference to it if you want to look it up yourself. And then, of course, as we found with all the other practices, you need to make sure that everybody is trained, all clinical staff who may insert and or maintain urinary catheters. You cannot assume that they're competent. Even if they have all the materials at their disposal that they'd be using, it doesn't mean that they're going to be using them correctly or at the right time. Standardized education, periodic retraining, and assessment. And with that, with those things in mind, we want to really get to our hospital stories. We have a few hospitals, folks from hospitals who are going to be talking to you today. We're going to start off with St. Luke in Idaho, and this is their Meridian Medical Center. We have Meredith Hotchkiss and Amy Bearwalker to talk with you today about the things that they're working on there.
Hello, I'm Meredith Hotchkiss, and I'm the infection prevention practitioner for St. Luke's Meridian Medical Center, which is a 200-bed full-service community hospital providing inpatient and outpatient care. We provide surgery, emergency care, maternity services, and a lot of cancer treatment. I'm sorry. And so I represent Meridian, the med-surg units. We were having an issue with Foley catheter infections. So fifth floor Meridian is a surgical unit, 42 beds. They admit orthopedic, general surgery, urological surgery, gynecological surgery, plastics, and some medical overflow, along with med-surg sixth floor. That's mostly a medical unit, 32 beds, with some surgical overflow, and
And this is Amy Bearwalker, and my role regarding catheter-associated UTIs within our facility is part of the UTI task force, where I help to facilitate that meeting. We've had this group together in place since 2006, and our group consists of membership from infection prevention, administrative leadership, performance improvement coordinators, clinical nurse specialists, nursing staff, and we also have unit-based UTI champions. And these are basically individuals who are either RNs or CNAs who are on the units helping drive practice, and they conduct audits. They assist us with reviewing cases if needed, and are just out there basically being the educators on reducing catheter-associated UTIs. We also have a urologist that's on our UTI task force as our physician champion, and then we also have education representation. With this group, we currently meet monthly and really just discuss the practice changes, look at our policies. We do review cases and look at the rates each month, and look at evidence-based practices that are out there, and just trying to make sure that we're following all the most recent guidelines and the most recent recommendations. We also do make product recommendations and look at different products relating to reducing UTIs. And then ultimately, just making all recommendations in decreasing our numbers. Currently, we're discussing the practice that Meredith is going to be going over here shortly, that med-surg put into place out in Meridian regarding bathing and the success that they have. And our hope is to move forward house-wide and hopefully system-wide with this practice, since Meridian has had such great success.
Okay, we realized on fifth floor Meridian that we were having a problem with a lot of UTIs, so we did a 2-year retrospective study, and that involves the PI coordinator, infection prevention, the clinical nurse specialist, the unit-based educator, and nursing staff. And we also involve the emergency department. One thing we noticed were that hip fractures were they accounted for our highest rate, and so we looked at the need of catheters and skip measures and trying to get those catheters out. We looked at evidence-based practice. We, like the person who spoke before us, we did fully care skills labs. We did it for all CNAs at the time, where we made sure we noticed that all of their practice was just kind of all over the board. So we standardized that, taught them one way. We also noticed, looking at evidence-based practice, that basin bathing was related to catheter-associated urinary tract infections. We primarily used a study by Dr. Mark Chasen, who has, right before that, he joined St. Luke's. And so we discussed it with him, and we eliminated the basins for Meridian 5 and 6, and we moved to comfort baths. So we did a lot of education with that. It involved a lot of educating the patients and the nurses. They all didn't feel very comfortable with the idea that the bag was their bath. We also worked at charge nurse reporting sheets, tracking physician orders and fully days, and then we created a physician letter to put in the chart to renew the order or address the catheter. So some of the pros and cons we found. Pros, cost. It takes a lot less nurse time and tap time, so our productivity went up. A bed bath that can take about 30 to 40 minutes took about 10 minutes. They were easy to use. They come out warm. They smell good. Urinary tract infection, you'll see in a moment that our rates have been excellent. We are going by evidence-based practice guidelines, and we standardized the product on both units. And like I said, with productivity, that goes with efficiency. Some of the cons, cost, it's a switch to go from, thinking of productivity and then into the hard cost of using the comfort bath. Patient satisfaction, we had, I believe, one complaint where someone said they felt sticky, and we did get a few complaints because the scripting wasn't initially done correctly. So once we worked with them, we have not had a complaint in over a year. And then nurse cap satisfaction, the nurses just love them, and so do the caps, because the bed bath is much quicker and easier, and you don't splash the water on the bed, and it's warm. So they really like the warmth of the bath.
So the next two slides, I just wanted to go over Meridian's data and show you the success that they've had. Currently in Boise and in Meridian at our facilities, infection prevention does conduct house-wide surveillance for catheter-associated UTIs in all departments who do collect the Foley catheters. So we can break out individual units. We can look at Boise-specific, Meridian-specific UTIs, and then each individual unit. And then we do go over these with our PA coordinators, with the units, just so everybody is aware of what their numbers look like. So this first graph here, this is Meridian 5th floor, and their last catheter-associated UTI was July of 2010. They implemented the removal of the basin bathing and the comfort bath December of 2010. And as you can see, those spikes that we had through January of 2008 through 2010, those represent one or two cases each month. And then the next one, this is Meridian 6th floor. And pretty much the same thing. Their last catheter-associated UTI was December of 2009. They also implemented what Meridian 5 was doing with the removal of the basin bathing and implemented the comfort bath. And as you can see, both of these departments have had great success and got our rates to zero and have sustained those numbers. So we're pretty proud of those units for what they've done.
One thing I do want to bring your attention to is, as you're aware, we do not call infections with asymptomatic urinary tract infections. And so before we instituted the comfort bath, every month I had to look at quite a few of the asymptomatic ones, and we would call them, and those have decreased dramatically in that time also.
So moving forward to get the house-wide implementation, I mentioned before that we are discussing this, we have been discussing this and currently discussing it in our UTI task force meetings, and we have approved to move forward with it. Meredith and I actually presented at numerous nursing shared governance committee meetings in February and got approval to go house-wide in the adult population. And currently we're working with the rep of the pre-moistened bath wipes to get warmers stocked on each of the departments. And we're hoping next to just determine our go-live date, and that's going to be dependent on our ordering information, making sure that we have the product here ordered, have it stocked, and then also getting education out to the staff prior to it on usage, on the patient scripting, and then reminders to not flush them in the toilet. That was one thing also. And then we're also just going to continue to implement this with our CNAs and the skills lab that they have yearly. So with that, we're hoping to continue to have great success and get our UTI rates down to 0 and sustain that like Meridian 5 and 6 have done.
Thanks so much, Amy and Meredith. This is Tina. If you could pass the ball back to me. We'll advance on to our next hospital, Eric Wallace. He's the nurse manager for the cardiovascular ICU and emergency department at the Swedish Medical Center Cherry Hill campus, and he's part of a larger team of critical care staff that are focusing on CAUTI prevention across the Swedish campuses. During on-site visits at Swedish earlier, I guess late in 2011, I learned about their unique approach to sustaining efforts and engagement in CAUTI prevention, so kind of on that sustaining piece. And they do it through an innovative rotating critical care calendar that focuses on 3 different HAIs, one of which is CAUTI. We had the good fortune to hear from 2 of Eric's colleagues during a Washington State Hospital Association webinar this morning who talked more broadly about that whole structure and approach. Today, Eric's going to take us for a more focused look at the maintenance compliance tool that they use. So, Eric, take it away.
Thank you. I'm going to be talking a little bit about our what we consider a novel approach in sustaining the gains and holding the gains. Like most of us, our big focus is on CAUTI, bloodstream infections, catheter-associated bloodstream infections, and ventilator-associated pneumonias. So instead, we realized that each month we look at the data. And some months we would see an uptake in one and kind of focus on that. That would go down, and then other months we see an uptick in another hospital-acquired infection, and we'd focus on that. That would go down, and another one would come up. So we figured a fairly innovative way to kind of sustain the gains is to each month have a focus. And it's not that we wouldn't be working on other hospital-acquired infections during that course of time. It's just during that month, a main focus during our huddles with our staff, during our staff meetings, during our electronic communications, and also during our audits would be on a specific hospital-acquired infection. So January is CAUTI month, and then February is bloodstream infection month, and then March is BAT month. So right now our focus is BAT, but next month in April we'll refocus back on CAUTI, and it rotates in a quarterly fashion like that. So not only do we do a lot of focused dialogue with our staff on that specific month, so in April we'll do a lot of dialogue with staff on CAUTI through our change of shift huddles, through our newsletters that we have on our units, through many modes of communication, but also through auditing. So for charge nurses at night and during the day, and I ask my charge nurses to complete this at least twice a week, so twice on night shift, twice on day shift. The charge nurse goes into each room with a Foley catheter, and they utilize a tool that you see in front of you, and they review each of the component with the bedside nurse. The idea behind this is this focus, I call it focus rounds. It's an opportunity to go through each of those core components which we've identified as important maintenance bundle elements in the care of a Foley catheter. It keeps it more in the forefront of their mind versus sporadically sending out information or reminders about those components. And they do that for each patient with a Foley catheter. So if it's 12, it's 12 audits they'll do, and night that twice a shift on for that week, for each week, and then twice during the day for that week, and continue it for the month. This we do in addition to our multidisciplinary rounds, which was elaborated on a little bit more this morning, where we always ask the question, can the Foley be removed? Why do they need the Foley? So we're working towards operationalizing more clear criteria on when a Foley is needed and when it's not. For these focus rounds, the assumption is that the Foley is in because it needs to be in, although a big piece of the dialogue with that focus round is, why does this person need a Foley? And it needs to be a very clear answer, not to simply, yes, you need a Foley, no, they don't need a Foley answer, but why, if yes, why, be very specific. You can see for each of those components, we developed this through PSA trials, what worked for our staff, what made sense to us, what did the evidence and the literature suggest. So we look at making sure the catheter is secured, we make sure the bag is less than 2/3 full, that it maintains a closed system, so that red seal is intact. And if it's not intact, why is it not intact? By doing these audits, we actually recognize that our ORs were coming up, our OR patients were coming up from surgery without a red seal intact. And upon further investigation, it just turns out that through their process, they just never had an intact system. They would put a Foley in and then put the drainage, connect it to the drainage bag. So by working with the OR team through this identification, now all the OR patients come up with a red seal intact. Then is the drainage bag attached to the side of the bed below the level of the bladder, making sure that piece is addressed, making sure the bag is not laying on the floor, and that we document cath care. So part of this focus audit is the charge nurse and the bedside nurse go into the patient's medical record and actually review the charting for catheter care to make sure it's been charted properly. And then we also focus on removal of the Foley. And if it hasn't been removed in 40 hours of insertion, why isn't it? We struggle with our surgery versus non-surgery patients, and that surgery patients, that removal at 48 hours is automatic in our post-op order sets, but it's not the case for our medical patients. So this helps us catch those medical patients where that's not as automatic. That is our UTI bundle element for maintenance element. Happy to answer questions people have. I think at the end of the conference is what we decided.
Thanks so much, Eric. I think it's a great way of putting in process a way to collect data as well as to open conversation, and that help you identify those sort of subtle things that can be tweaked to get you all closer to zero. I'm going to go ahead and pass the ball over to Mark, who is our next hospital presenter. Mark and Jennifer, or I'll pass the ball to Jennifer, who's with Mark. Jennifer, if you click on the slide, you can then advance it and introduce Mark.
Hello, everyone. I'm sitting right here next to Mark Chavez, so I will let him introduce himself, maybe mention just a couple of tidbits about his facility, and tell you about the work they've been doing here.
All right, so my name is Mark Chavez. I'm the Infection Prevention Coordinator at CAUTI Health, specifically CAUTI Medical Center. I'll tell you a little bit more about our facility and some of the projects that we've been working on. We'll be presenting two projects. The first is measuring the effect of a multifactorial intervention to decrease CAUTI in the acute care setting. A little bit about our facility. We're located in beautiful Coeur d'Alene, Idaho. We're a 246-bed, not-for-profit district hospital. And in 2006, we actually received AMCC magnet designation, and we've maintained that. So this has been great for our facility, and there's a large focus on nursing research. So, a little bit of background. We looked at the fact that urinary catheters can place patients at risk for catheter-associated UTI. And these infections, we can document, have prolonged hospitalization. They can increase healthcare costs and may result in sepsis or death. So really the problem that we identified was that there's evidence-based guidelines that have been developed to standardize care and reduce the risk. However, there's no clear consensus on the most effective implementation. So we adopted a method here and developed a study around that, and our outcome measures for hospital-wide intervention, we measure catheter-associated UTI rates for the entire facility, We also measured the rate of device utilization for all indwelling urinary catheter days over patient days, and also wanted to look at the percentage of devices removed by postoperative day 9 for our STIP 9 measure. So methods, we used the pre-test, post-test intervention, and we looked at descriptive statistics and independent t-tests. And really what we did was a multifactorial intervention, including policy revision, daily medical necessity documentation, form that was placed in the physician order section of the chart each day by nursing. We did a computer education module through HealthStream, and we provided systematic surveillance and feedback to each of the nursing units. So our policy revision included criteria for insertion of a Foley catheter, ensuring that we're not placing Foley catheters unnecessarily. We had a daily medical necessity order. Pre-insertion perineal care was educated to all nursing staff and CNAs, as well as the inclusion of a securement device, collection bag maintenance below the level of the bladder off of the floor, and perineal care each day, again in line with removing the bath basins and using the bath in a bag product. So our computerized education module we developed using HealthStream, and it was required for all staff. So we used one module for nursing, which was in-depth training, including insertion of care. Then also there was a module developed for ancillary staff, anybody that touched the patient, to ensure that they were educated to maintain the drainage bag below the level of the bladder, to keep the drainage bag off of the floor. And one interesting point here, this actually resulted in house-wide purchasing of hooks for all of our IV poles to actually hang the Foley bag for patients that are ambulating. The data collected from 9 inpatient units. Our pre-intervention period was March 2009 through March 2010. Post-intervention was April 2010 through December 2010. Here's our graph. So we had a pre-intervention rate of 2 catheter-associated UTIs per 1,000 device days. Post-intervention rate was dropped to 1.4 with a P of 0.68. So this is our device utilization. We actually did have a statistically significant reduction in utilization, approximately 20% reduction in utilization rate. So the conclusions of our study was that we did have a significant reduction in device utilization. However, statistically significant, we did not reach statistical significant reduction in catheter-associated UTI. We did reach our goal of a 30% rate reduction. Some of the limitations, and this was hit on earlier, is that variation among units in compliance with the new practices likely influenced the finding. So we had some units that were more compliant than other units, and looking at tools and processes to improve clinician compliance with daily assessment for medical necessity. So this takes a lot of work and a lot of focus for nursing staff as well as medical staff to continue to look at this as an important process to ensure that they're actually filling out the daily medical necessity form, and that each patient on the unit that does have a Foley catheter is included in that. So moving on to our second project, so we saw our 30% rate reduction. However, we weren't to our goal of 0 catheter-associated UTIs outside. So our second project is looking at silver-impregnated latex urinary catheters versus nitrofurazone-impregnated silicone Foley catheters, and we conducted a pilot study. So we worked with the company Rochester Medical, who is the manufacturer of the product, who provided a 90-day trial of the product. So one of the reasons for this is we looked at this new product, we looked at the HCPAC recommendations, or the Healthcare Infection Control Practices Advisory Committee, published in 2009. And they say if catheter-associated UTI rate is not decreasing after implementing a comprehensive strategy to reduce rates of CAUTI, consider using antimicrobial or antiseptic impregnated catheters. So we go on to continue talking about the comprehensive strategy to include the minimum, which we felt that we met by implementing our bundle. So the objectives, the purpose of the study is to evaluate the effect of the product conversion. Our measures were catheter-associated UTI rate, our facility costs, and also we looked at utilization of antibiotics for treatment of catheter-associated UTI. The So one of the things, the background information here, we looked at our catheter-associated urinary tract infection pathogens. So again, in line with probably what most facilities are seeing, our gram-negative organisms, our E. coli, our pneumoniae, and our enterococcus being our big offenders. So and then we also looked at published in vitro testing and susceptibility. So we saw that looking at the nitrofurazone susceptibility, this product looked like it could offer some promise here. So that was 2009 numbers. Here's 2010 numbers, and we see that in 2009 we had a total of 27 catheter-associated urinary tract infections, and we implemented our comprehensive bundle in 2010 and dropped that number down to 15. So in 2010, again, E. coli and enterococcus being our top offenders, as well as the pneumoniae in there as well. All of which were susceptible to the nitrofurazone product. So, here's our results. Looking at our hospital-wide graph, and I apologize, there's a lot of information here. So our top line is our percent of utilization. So this would be device days over patient days. We see back in the beginning of 2010, a great reduction there in utilization with incorporating the bundle, and also a reduction in our rate of catheter-associated UTIs. So we implemented the new product on July 17th, 2011. We had one catheter-associated UTI there attributed to our silver latex product. And what I'd like to point out is that we went August, September, October, with zero catheter-associated UTIs, and that was our entire 3-month pilot project. November, we had one catheter-associated urinary tract infection, and this again was in a temperature sensing Foley catheter, so this was our silver latex product. And again, December and January, we continued on with a rate of zero catheter-associated UTIs. So the boxes on the bottom, 2009 total cases of 27 with a rate of 2.8 catheter-associated UTIs per 1,000 device days. Significant reduction in 2010 to a rate of 1.6, and sustained the gains and actually gone a little bit further in 2011 with a rate of 1.1. And looking at statistical analysis, we have our two-sun chart or cumulative chart, and what we're looking at here is that we are trending towards our lower control, and it looks like if we continue on this path, by the end of March, beginning of April, we would be able to say that we've statistically significantly reduced our catheter-associated UTI rate with our new product. So significance and implications of this would be that we looked at our average internal cost using our Premier software, and again, this is based on charge information, so there is some variation in here. However, we were able to average an actual cost, an internal cost of about $18,000 per incidence of catheter-associated UTI, which is much higher than the published data for a national average cost. So using this number, a nursing-led research initiative potentially saved the facility more than $800,000 over a 2-year period. So big gains for the organization as well as our patients. Significance and implications. Nitrofurazone-impregnated catheters may reduce catheter-associated UTI events among hospitalized inpatients. And longer time periods will be needed to increase confidence in the preliminary findings. However, it could be theorized that new products may allow organizations to reach goals of zero catheter-associated UTI events. Contact information, a list of our references.
So this is Jennifer, and I love this part of the talk when we get to really let everybody's stories sink in and think about, and we ask our audience the question, and this isn't rhetorical, so we'll open up the lines here in a minute so that you can ask questions and make comments in response to these questions or even just some of your own. What excited you about what you heard? And in that, what is it that you heard that you think that you could do by next Tuesday? The thought that quality improvement PDSA cycles don't have to wait for committees to start and end them, that there is something that you can try on one patient or one floor very quickly by next Tuesday. So think about that. There's some great examples here today from these 3 different hospitals. So I'd like to go ahead, Alma. I think this is the point in the talk when we would like to go ahead and just open up the lines, and hopefully nobody has their lines on hold or anything like that. And we want to hear what excited you about what you heard or what's different. What might you want to try at your facility?
One of the ones in chat was from Mark to Amy and Meredith. And he asked, is your annual CNA skills lab mandatory or specific to catheter care or other tiers? So Amy and Meredith, you'd like to respond to that?
Yeah, the skills labs, they are mandatory, and it's kind of all cares is what they look at. So Foley cares, peri-surface bathing, so they kind of address quite a few things at those skills labs.
How frequently do those skills labs happen?
They have to go to skills lab every year, just like the RNs do.
Okay. And then the other question I see from chat, I'll just go ahead and ask this one, and then I'll stop talking and let the folks on the line start asking questions. There was a chat question from Gina Maggard, and it looks like she's wondering if Amy and Meredith, if you'd had any problems with flushing. The wife, she says, our plant op is really dragging feet because clogging pipes with flushing the comfort bath.
We did have a problem, and Boise also uses some, and we had complaints from the city, complaints from maintenance. We had flooding in some of the bathrooms. So what we did was we really increased education. We hung signs in every bathroom, and you could actually get some that are professionally made from the company that are wipeable. And we've just put some. Right now, we just have homemade signs that we did ourselves in every bathroom.
Have you had any incidents since just the increased signage?
No, we have not. And the other thing is if a patient is in a chair bathing himself, what I've instructed the staff to do is leave them in put the trash can next to the patient and instruct them to throw them in the trash can.
This is Jennifer. There's from Kristen. We have a question. Is everyone using the NHSN definition for CAUTI? And so I'm thinking we're asking this question, especially at the hospitals that we have on the line, or that gave their stories today.
This is Mark Chavez, and yes, we do use the NHSN definition for catheter-associated UTI. Those numbers did not include asymptomatic bacteriuria.
This is Amy, and the same thing here. We are using the same definitions.
This is Eric. I'm assuming so. When my epidemiology department says you have a UTI, I count it as a UTI.
And this is Jennifer. While we're waiting for other people to type up with questions or comments, or that's cool, I wanted to ask Eric, I just wanted to reflect back on your story again, but you were saying for the once-a-week audit tool, which I just think is awesome, did you say that a charge nurse goes in, and do they go in with the nurse who's caring for that patient and or the CNA?
Correct. It's a minimum twice a week, twice during the day, twice at night, so twice during a week period at minimum, so if they can do it more, great. Yes, it is the charge nurse, and that goes into the room with the nurse caring for the patient to review those bundle elements. To be honest, I hadn't thought about having the CNA be part of that focused round, so that's a great concept, something I'll probably roll out because it's really important.
Yeah, that seems like maybe a good opportunity. So it's twice a week, twice at night during the week, and twice in the day during the week.
At minimum, correct.
At minimum. And I like that not only is it an audit tool, but it's kind of a mentoring tool.
Right. It does collect data, but which is fine, which is great. It's important to have. But I think the most valuable part of it is it's almost a ritualistic dialogue on a consistent basis you have regarding these hospital-acquired infections.
Ritualistic dialogue. I love it.
My name's Raquel, and I have a question for Mark.
Okay.
Hi, Mark. Can you tell me that this brand of catheter that you converted to that was impregnated, I haven't heard of that brand. How did you decide to go with that brand over some of the other, Bard or Medline? What drove your decision, and did you use a different catheter brand before you converted?
We did, and that's a great question, and one that there was a lot of discussion around that. We actually converted from a Bard product, a Bard silver latex Foley catheter, and what we did was we did a literature review. We looked at other facilities that were using the Rochester product, and we also looked at the published data. So, and we actually had conversations with another hospital in Montana who has been using the Rochester product and has actually gone a very extended period of time with zero catheter-associated UTIs. So some of the concerns that were raised with the nitrofurazone were a question on resistance. So the delineation there is that nitrofurazone is not the same as the nitrofurantoin or the oral antibiotic. It's been used for a long period of time in topical wound care, and some of the other questions were questions of resistance. So there's been studies looking at the question of resistance, and there has been no documented changes in resistance patterns to the nitrofurazone. And the theory there is that there's multiple modes of action with nitrofurazone. So, and in that reference list that was in the slide set, there are several good studies looking at the Rochester product.
Okay, thank you.
This is Cheryl Bergery from Degas.
Hi, Cheryl.
I really like this bundle compliance audit tool. I tried to do something similar on a daily basis, check for indications for Foley catheters, and absolutely had the most trouble getting people to do this on a daily basis. I think weekly is probably a whole lot more doable, especially if I try it in the ICU. So I'm going to throw that out there and see if they'll do that since it's my area of focus. But it looks very similar to what Bard did when they came out and did a point prevalence of bundle compliance. It's real similar to what they had, which is great. And so it looks like this is something that can be easily replicated. Is this form going to be shared also?
You bet. This is Tina. We will distribute that form to all the CAUTI Action Network.
Okay. The other thing interesting that came up in our point prevalence is that the hooks on the bed that are intended for hanging the Foley catheters, when the bed is in low position, when you're trying to do fall prevention and have your bed in the lowest position, it ended up that we had quite a few catheter bags that were touching the floor because the beds were down in the low position. So just the way that the beds are manufactured now is causing some additional challenges with that particular measure. Okay. Has anybody else noticed that?
We have not at Swedish Medical Center. It's interesting that that's a roadblock we've encountered. I hadn't thought of it. We haven't seen that at Swedish. I'm sure it's just the bed we use or not.
We've seen it at Virginia Mason. We'll just have to figure out where else to hang the thing, I guess.
Parts and when was this last night?
I see on the chat a request to distribute Eric's bundle form along with the timeline he uses, and I'll be sure to do that.
So, Eric, this is Jennifer again. I wanted to ask you, I also like this really simple concept of sort of changing your infection prevention topic, what you're communicating to the front line each month. And I was curious if you had materials that went along with that, or are you just sort of changing your topic of discussion with them?
No, our focus for the dialogue for that month is that respective topic. So for this month is March, and it's Bath month. We have maintenance bundle tools very similar to the CAUTI one that we showed, relevant for all three of our hospital-acquired infections that we're focusing on. So we'll utilize that tool to framework our discussion, and that's the primary tool we use. But the rest of it is dialogue. But we use that tool for the dialogue, and this tool has stayed the same.
Okay, so, and just so I don't mistake it, so that you have bundle tools that are similar to this one that we're all in love with, and now do you continue using the tool through each month that comes along, or do you just do it quarterly?
We use so for this month we're using a VAP tool. Next month in April we'll use that CAUTI tool throughout the whole month, and then we'll use the CAUTI tool again, and the same CAUTI tool again in July when our next CAUTI focus is.
Okay, so when you're doing this auditing and mentoring, you're doing it for a month at a time per topic.
Correct.
And so they're not getting completely tired of seeing you and sending you the same thing over and over.
Exactly.
Oh, that's nice.
I just love the idea of the rotating calendar. I love it because it provides an infrastructure that's, reliable and expected and predictable for touching on those topics. But it also, because it's rotating, it seems like it opens up the opportunity for kicking off new initiatives, kicking off a new education piece, doing root cause analysis focus. I just think it's a really great way to sustain without burning people out. Neat idea.
And there's CAUTI, VAP, and
bloodstream infection.
Got any others in the pipeline?
Those are the three that we've been really focusing on that we want to completely eliminate. So until we completely eliminate those, I think we're going to maintain our focus on those three.
Well, I know that we're focused on CAUTI right now, but would you mind sharing all three audit tools?
Yes, I don't have a problem with that at all.
Great.
Other questions out there, or offers, requests, inspiration?
And unfortunately, this is Eric. I have to go. I'm also carrying the nursing pager, and there's something I have to respond to, so I'll have to get off the phone. But feel free to send me any email questions you may have.
Thanks so much, Eric, for sharing with us today.
Thank you.
Take care.
So this is Jennifer, and we see Jenna has posted a question mark next to me. Can you tell us where you got your hooks for the ID poll? And he can find out, right?
That's a great question, and I will find out.
He can find out, and then when we send out our information, we'll send that with it.
Jennifer, if there's time, Mr. Cal, can I ask another question of the group?
Absolutely.
I'm just wondering if anyone is experiencing any challenges with Foley's draining into the urine bag. We know about the valve in the bag. That's an ongoing probably throughout time. But if they've seen any, pattern with any type of product or anything with challenges with drainage.
Anyone? Anybody got an idea for that?
This is Mark, and I can tell you, when we did our initial bundle and looked at keeping the Foley catheter bag below the level of the bladder, one of the issues that we saw and identified was seeing the Foley bag up on the gurney as the patient was being wheeled through the hallways. And what can happen is there's a vent in the drainage bag that if that becomes wet will actually cause a bit of a vapor loss there. So if the catheter bag is inverted or flipped up, that can cause drainage issues with most of the products that we've looked at.
Right. Okay. Thank you.
This is Tina. That just made me think of a neuro ICU patient. On an earlier call today, Swedish, one of Eric's colleagues, talked about on the neuro ICU what they noticed when they did some root cause analysis on some of their events. was that they were happening more frequently with the neuro patients, and that the neuro patients were more frequent travelers on and off the floor, and it prompted them to do some education with transport teams around where those bags go when you're getting patients in and out of beds, onto gurneys, et cetera. And it just made me think of that in terms of if you've got a bag up on your belly, and that is getting an area of the mechanism wet and causing problems.
Great, thank you.
Well, this is Jennifer, and I want to make sure that we keep an eye on the time. We're getting close to the end of our hour together, and so I'm just going to say if there's any other questions, any other requests for sharing tools or anything, please send them our way, and we'll get you everything we possibly can. We are recording this webinar, too. We will be sending that webinar link to you. And also working with Intermountain Anchor to get that posted to the website, so we have a place where we can go regularly for that. Tina, can you go ahead and move on to the next slide? And just so, these are some great ideas today. Oh, I have the ball, don't I? I have the ball. Never mind. I just wanted to say there were some great ideas today, and there are some great ideas that could be implemented by next Tuesday, from really considering eliminating basin phasing or doing your own PDSA on a unit, just like St. Luke's, doing this really cool, fresh audit that Eric shared, and Mark shared a variety of things, but it's also, what I liked about it was, even when you think your rates are low, there's always another way to look at possibly driving them lower, and sometimes you have to look at some of those other recommendations that come that are in our HICPAC guidelines to do that. So next up in our series, and I do see a question right now, what brand of bath bags does St. Luke's use? Amy and Meredith?
We use Comfort Baths from Sage. They came and set us up with a warmer at no cost, let us trial them, and spare your wife. That works very well.
Thank you for sharing that. So next up in our series, we have one more pillar in our 4 pillars of prevention. We're going to talk about removal of catheters and some innovative ways to hardwire that process. If you have something that you're particularly proud of, Tina and I want you to email us or call us or let us know. Hot on that list would be any nursing-driven orders for removing catheters. But there are all kinds of other stickers, tools, and triggers that we would want you to share with other infection preventionists, especially if they're being particularly effective for you and your hospital. It's a new date. Please take note of that. We'll be sending that out on our flyers. We have changed the date to May 3rd from the end of April. Tina and I both had conflicts, so we hope you can join us. It's the same type of thing. It's still a Thursday. It's still at the same time. And then finally, we want to give you a big thank you, and just note that when you close out of this webinar, when you X out, you'll be offered a brief survey monkey. Please let us know how you felt about this, and if you have recommendations for future topics or just how to change things to make it more valuable to you. I want to take a moment to thank Eric and Amy and Meredith and Mark. This has been a super conversation. And Tina, would you like to say anything?
Thank you, everybody, for joining us today, and keep up the good work.
All right. Goodbye, everyone.
Bye-bye.